You're listening to Health Professional Radio with Wayne Buckler. Today my guest is Matthew Carroll, President of the Mental Health Tribunal, and Matthew joins me on the phone from Victoria in Australia. Welcome to Health Professional Radio, Matthew.
Thanks, Wayne.
Matthew, most of our audience are clinicians in one sense or another. Many of them work in the health profession in hospitals. I made the assumption when I started in this job that everyone in the health profession knew everything else about the health professions. But in fact, I find that's not so, that there are big gaps from one discipline to another, and even, I have to say, in some cases from one ward to another. So today we'd like to chat to you about what it is that the Mental Health Tribunal does and just provide a background for some of our colleagues. Can you tell us what it is that the Tribunal does and how it came into existence?
Sure. Look, as you mentioned in the introduction, Wayne, I'm from Victoria and talking about the Victorian Mental Health Tribunal. Given the breadth of your audience, I think it's probably of value to point out that every state and territory in Australia has its own mental health review board or mental health review tribunal. I'm the president of the Victorian Tribunal. There are a lot of similarities about how we work, but as is often the case, different states have different legislation, and so it's not identical across the board. But in broad terms, the role of any mental health tribunal, or its equivalent here in Australia, is to be examining situations where it's felt necessary to treat a person experiencing severe mental illness on a compulsory basis. So that is where they're on an order requiring them to have treatment for a severe mental illness, be that in hospital or in the community. The role of the tribunal is to look at whether or not those orders should be made and whether or not a person continues to meet the criteria to be on such an order. And we also have a particular defined role in relation to ECT for patients who are unable to provide informed consent themselves, and in those situations we're called upon to decide whether or not to make an order allowing for ECT to be used in the treatment of a person.
Now, ECT is electroconvulsive therapy, digging back into my dim, dark nursing training. Why do you draw that out as a separate issue?
Look, it's, I suppose, to take a step back from the specifics, when mental health tribunals or mental health review boards are deciding whether or not to make or continue an order requiring a person to have compulsory treatment for a severe mental illness, our role isn't to make specific treatment decisions. So we're there to decide whether the order facilitates treatment, and then it's a matter of discussion and negotiation between a treating team and the individual consumer or patient as to what that treatment includes, so the particular medications that might be used and whether or not it's in an oral form or in an injectable form. They're all issues that are worked out, as I said, between a treating team and the consumer and not decided by the tribunal. But generally, and Victoria was one of the last states to introduce this, where ECT is being proposed to be used as part of a person's treatment and they are not themselves able to provide informed consent, the tribunal is a safeguard or a forum in which to decide whether or not ECT can be used. And look, the reasons for taking a particular approach to ECT is that it is a treatment that there is a great deal of, I suppose, a degree of suspicion and a degree of misunderstanding about in the broader community, and it's thought that it's a treatment that requires a higher level of regulation than some other forms of treatment.
I see. Now, the tribunal's a statutory body, meaning it's created by legislation.
That's right.
Do you have a view about, do you benefit one particular party? Are you a patient advocate? Can you explain to me how you fit with the various parties involved?
Sure. No, that raises some really important points. So the tribunal isn't an advocacy body. We're an impartial and an independent tribunal. And we conduct hearings in order to make decisions on the issues that we're required to determine. And we facilitate, conduct those hearings on an impartial basis, and we hear, I suppose in a very legally, we hear evidence. We tend to talk more about information and perspectives more so than evidence, simply because we do try to avoid legalistic language in this jurisdiction. But treating teams will make an application to the tribunal saying that we believe this particular person requires compulsory treatment for a given period of time, and these are the reasons why we think that's the case. And there are specific criteria set down in the Mental Health Act which govern whether or not compulsory treatment is allowed. The treating team provides their perspective on why it thinks those criteria are met. The consumer or the patient then provides their perspective, and they may be assisted by a legal representative or a non-legal advocate, perhaps a peer worker or a friend or some other advocacy service. The role of the tribunal is to hear that material or hear that information impartially and to ask questions, to tease issues out, to seek to understand everyone's perspective as thoroughly and as fully as possible, and then make its own independent decision upon whether or not a treatment order should be made. So in that respect, we're not an advocacy body. But in terms of who do we serve, I suppose the starting point or the primary objective is to be there as a safeguard for consumers and patients to ensure that compulsory treatment is only used where it's legal, where the criteria set down in the legislation are met. But in performing that role, I think we also provide a useful form of assistance or a useful forum for clinicians as well, because it's a forum in which matters that are often very strongly disputed can be discussed. It's the tribunal that takes on responsibility for making the decision. It's not the treating team themselves that are making the decision. And then once a decision is made, we step out of the picture, leaving treating teams and consumers to then interact with each other on either a compulsory or a voluntary basis.
That's a very significant point. I think I've not ever been in the position of having to make that sort of decision because I'm not a clinician. But I imagine that there is often elements of an ethical dilemma where some sort of forum to get an impartial examination of the issues and facts would be very helpful. Is the tribunal relevant to health professionals in other ways?
Look, I suppose the tribunal's role is quite specific and quite deliberately narrow, and even in relation to mental health, we have a very narrow range of focus. Compulsory treatment is a very significant and important aspect of the overall delivery of mental health services within the community, but it's one small aspect, and it's often interesting to reflect on the fact that so much of the public discourse is about mental health is quite rightly about the lack of access to, or lack of sufficient access to treatment, and people seeking to access services but finding that that's not as it should be in many instances. Whereas we are working with a very particular group of patients, and they're a group of patients who are within the service system and are receiving treatment, but may at times be quite opposed to that and not wanting it. So it is, I suppose, a very niche or particular area that we are involved with.
You're listening to Health Professional Radio, and my guest this morning is Matthew Carroll, President of the Mental Health Tribunal from Victoria in Australia. Matthew, can you give me some sense of the numbers involved, or I'm just trying to get my head around how frequently mandatory orders are made?
Sure. We've just gone through significant changes in Victoria, so the tribunal has only been in operation since July of last year, but prior to that there was a Mental Health Review Board, and for a number of years the Mental Health Review Board had a very stable caseload where it was conducting in the vicinity of 6,000 hearings per annum. So 6,000 hearings where it was deciding whether or not a particular individual should continue to be an involuntary patient. That pattern has actually, and it's to some extent a little bit of a surprise, that pattern has continued with our new Mental Health Act and the new Mental Health Tribunal. Mm-hmm. So as at the end, I did check some key stats for you before the interview. So as at the end of March of this year, so the 3-quarter mark for our first year of operation, the Tribunal had made 3,600 treatment orders. It had revoked just over 300 orders, so that a revocation means that at the end of the hearing, the tribunal decided that a person should no longer be a compulsory patient, and as I said, that has occurred in just over 300 cases to date, and we've also made just under 400 ECT orders. So, again, like the former board, we're on a path to and expecting to conduct about in the vicinity of 6,000 hearings for the first full year of operation.
And from my ignorant perspective, I'm surprised at just how big that number is. It's one of the things I guess you don't see a lot of exposure to unless you're, I guess, actively involved in that field.
One of the objectives of the new Mental Health Act that started in July of last year is that we should be, over time, reducing our reliance upon the level of compulsory treatment orders, and that voluntary treatment should always be preferred. And because one of the ways that it was intended for the Act to do that would be that the tribunal would see patients much earlier in their compulsory admission than the former board did, we actually thought that, particularly in our first year of operation, that we might have quite a significant spike in the number of hearings we were conducting. So, as I said, the board had a stable caseload of 6,000, and we're looking at the same caseload. So, given that spike hasn't occurred, it would seem that there are bound to be many explanations for that, and there hasn't been time to do particularly comprehensive or in-depth research into it as yet. But the initial indications are that the new Act has had an immediate impact in terms of pulling back or winding back the level of use of compulsory treatment orders.
It's interesting to hear, and given that it is a new Act and you're a relatively new body, what are the current events or issues or strategies that are occupying your time now?
Look, the focus is still very much on the implementation of a new Act. The new Act was a product of many years of consultation with the community, particularly consumers and carers, and also mental health clinicians and experts as well. In some respects, the new Act was catching up with more contemporary practices in mental health service delivery, but it was also making those contemporary practices more mandatory rather than discretionary. So it is intended to encourage a new approach, which is very much centred around patient participation in decision making, recognising the role of carers, the integral role of carers, and the need to consider their perspective. Really pushing a recovery approach to mental health care and treatment, and also supported decision making. Now, these sorts of changes don't happen within the first 9 to 12 months of a new Act's operation. It's a process of cultural change that will take many years. So I suppose the focus now is on the fact that we have gone through quite a successful commencement period where the transition has been reasonably smooth, and now it's a matter of focusing on the culture change and making sure that the momentum on that is maintained and that those changes become embedded over time.
Matthew, congratulations on the implementation of the early phase of that, and we wish you well with that implementation over time. Can I say thank you for talking with us today? It's been a fascinating chat and an insight into something that doesn't often get our attention here on Health Professional Radio, so thank you for that. If you just joined us, you've been listening to Matthew Carroll, President of the Mental Health Tribunal in Victoria, Australia. A transcript of this interview and a SoundCloud archive are available on the Health Professional Radio website at www.hpr.fm. My name is Wayne Buckley. You've been listening to Health Professional Radio.